Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Criselmer Docanes, clinical instructor teaching fundamentals of nursing practice. Today, we'll be talking about promoting psychosocial health in terms of self-concept, stress and coping, loss, grieving and death, sensory perception, sexuality, and spirituality. First, let's discuss self-concept. Self-concept is one's mental image of oneself. A positive self-concept is essential to a person's mental and physical health. Individuals with a positive self-concept are better able to develop and maintain interpersonal relationships and resist psychological and physical illness. An individual possessing a strong self-concept should be better able to accept or adapt to changes that may occur over the lifespan. How one views oneself affects one's interaction with others. Nurses have a responsibility to assess clients for a negative self-concept and to identify the possible causes in order to help them develop a more positive view of themselves. Individuals who have a poor self-concept may express feelings of worthlessness, self-dislike, or even self-hatred. They may feel sad or hopeless and may state they lack energy to perform even the simplest of tasks. Self-concept involves all of the self-perception, appearance, values, and beliefs that influence behavior and are referred to when using the words I or me. Self-concept influences the following: how one thinks, talks, and acts, how one sees and treats another person, choices one makes, ability to give and receive love, and the ability to take action and to change things. There are four dimensions of self-concept. First, we have your self-knowledge, self-expectation, social self, and social evaluation. Self-knowledge. This is the insight into one's own abilities, nature, and limitations. Self-expectation, however, is what one expects of oneself, may be realistic or unrealistic expectations. And social self, it is how a person is perceived by others and society. Lastly, social evaluation, the appraisal of oneself in relationship to others, events, or situations. What is self-awareness? It refers to the relationship between one's perception of himself or herself and others' perception of him or her. Thus, a nurse who is very self-aware has perceptions that are very congruent. Becoming more self-aware is a process that requires time and energy and is never complete. One important component of the process is introspection, which involves the nurse reflecting on his or her own beliefs, attitudes, motivations, strengths, and limitations. The nurse also gains insight into the self through working with other nurses who serve as mentors and by taking feedback obtained during regular performance reviews seriously and acting on it. Now let's proceed to the formation of self-concept. A person is not born with a self-concept. Rather, it develops as a result of social interactions with others. The term global self refers to the collective beliefs and images one's hold about self. It is the most complete description that individuals can give of themselves at any one time. It is also a person's frame of reference for experiencing and viewing the world. Some of these beliefs and images represent statements of fact. For example, I am a father, or I am short. Others refer to less tangible aspect of self. For instance, I am competent, or I am shy. Maintaining and evaluating one's self-concept is an ongoing process. Events or situations may change the level of self-concept over time. Having a basic self-concept includes how we see ourselves and how we are seen by others. There is also the ideal self, which is how we should be or would prefer to be. The ideal self is the individual's perception of how one should behave based on certain personal standards, aspirations, goals, and values. Sometimes this ideal self is realistic, sometimes it is not. When the perceived self is close to the ideal self, people do not wish to be much different from what they believe they already are. A discrepancy between the ideal self and perceived self can be an incentive to self-improvement. However, when the discrepancy is great, low self-esteem can result. Nurses, like other adults, view themselves based on both internal and external inputs acquired over many years. The ability to appraise one's own strengths, the desire to follow in the steps of role models, and the feedback received from colleagues and clients are some of the influences on the nurse's self-concept. Now let's proceed to the four components of self-concept. These are personal identity, body image, role performance, and self-esteem. Personal identity is the conscious sense of individuality and uniqueness that is continually evolving throughout life. People often view their identity in terms of name, gender, age, race, ethnic origin, or culture. Body image, it is the image of physical self. It is how a person perceives the size, appearance, and functioning of the body and its parts. Body image has both cognitive and affective aspects. The cognitive is the knowledge of the material body. The affective includes sensations of the body, such as pain, pleasure, fatigue, and physical movement. Body image is the sum of these attitudes, conscious and unconscious, that a person has towards his or her body. Now let's proceed to role performance. Throughout life, people undergo numerous role changes. A role is a set of expectations about how the person occupying a particular position behaves. Role performance is how a person in a particular role behaves in comparison to the behaviors expected of that role. Next, we have role mastery. It means that the person's behaviors meet role expectations. Expectations or standards of behavior of a role are set by society, a cultural group, or a smaller group to which a person belongs. Each person usually has several roles, such as a husband, parent, brother, son, employee, friend, nurse, and church member. Some roles are assumed for only limited periods, such as a client, student, and ill person. How about role development? Role development involves socialization into a particular role. For example, nursing students are socialized into nursing through exposure to the instructors, clinical experience, classes, laboratory simulations, and seminars. To act appropriately, people need to know who they are in relation to others and what society expects for the position they hold. Role ambiguity, however, occurs when expectations are unclear and people do not know what to do and how to do it, and are unable to predict the reactions of others to their behavior. Failure to master a role creates frustration and feelings of inadequacy, often with consequent low self-esteem. Now let's proceed to role strain. Self-concept is also affected by role strain and role conflicts. People undergoing role strain are frustrated because they feel or are made to feel inadequate or unsuited to a role. Role strain is often associated with sex role stereotypes. For example, women in occupations traditionally held by men might be treated as having less knowledge and competence than men in the same roles. Role conflicts, however, arise from opposing or incompatible expectations. In an interpersonal conflict, people have different expectations about a particular role. For example, a grandparent may have different expectations than the mother about how she should care for her children. Now let's have self-esteem. Self-esteem is one's judgment of one's own worth. That is, how the person's standards and performances compare to those standards and to one's ideal self. If a person's self-esteem does not match with the ideal self, then low self-concept results. There are two types of self-esteem. We have global and specific. Global self-esteem is how much one likes oneself as a whole. On the other hand, specific self-esteem is how much one approves of a certain part of oneself. There are many factors that affect a person's self-concept. First is stage of development. As an individual develops, the conditions that affect the self-concept change. For example, an infant requires a supportive, caring environment, whereas a child requires freedom to explore and learn. Older adults' self-concept is based on their experiences in progressing through life stages. Next is family and culture. A young child's values are largely influenced by the family and culture. Later on, peers influence the child and thereby affect the sense of self. When the child is confronted by differing expectations from family, culture, and peers, the child's sense of self is often confused. For example, a child may realize that his parents expect he will not drink alcohol and that he will attend religious services each Saturday. At the same time, his peers drink beer and encourages him to spend Saturdays with them. Next is stressors. Stressors can strengthen the self-concept as an individual copes successfully with the problems. On the other hand, overwhelming stressors can cause maladaptive responses, including substance abuse, withdrawal, and anxiety. The ability of a person to handle stressors will largely depend on the personal resources. It is important for the nurse to identify any stressors that may affect aspects of the self-concept. Next is resources. An individual's resources are internal and external. Examples of internal resources include confidence and values, whereas external resources include support network, sufficient finances, and organizations. Generally, the greater the number of resources a person has and uses, the more positive the effect on the self-concept. Next is history of success and failure. People who have a history of failures come to see themselves as failures, whereas people with a history of successes will have a more positive self-concept. Likewise, individuals with a positive self-concept tend to find contentment in their level of success, whereas a negative self-concept can lead to viewing one's life situation as negative. And lastly, we have illness. Illness and trauma can also affect an individual's self-concept. A woman who has had a mastectomy may see herself as less attractive, and the loss may affect how she acts and values herself. People respond to stressors such as illness and alterations in function related to aging in a variety of ways. Acceptance, denial, withdrawal, and depression are common reactions. Next, let's discuss sensory perception. An individual's senses are essential for growth, development, and survival. Sensory stimuli give meaning to events in the environment. Any alteration in people's sensory function can affect their ability to function within the environment. For example, many clients have impaired sensory functions that put them at risk in the healthcare setting, and nurses can help them find ways to function safely in this often confusing environment. To begin with, let's define sensory perception. The sensory process involves two components. We have reception and perception. Sensory reception is the process of receiving stimuli or data. These stimuli are either external or internal to the body. We also have here sensory perception. It involves the conscious organization and translation of the data or stimuli into meaningful information. The external stimuli are visual or sight, auditory or hearing, olfactory or smell, tactile or touch, and gustatory or taste. Gustatory stimuli can be internal as well. There are other types of internal stimuli such as kinesthetic or visceral. Kinesthetic refers to awareness of the position and movement of body parts. For example, a person walking is aware of which leg is forward. A related sense is stereognosis. It is the ability to perceive and understand an object through touch by its size, shape, and texture. For example, a person holding a tennis ball is aware of its size, round shape, and soft surface without seeing it. On the other hand, visceral refers to any large organ within the body. Visceral organs may produce stimuli that make a person aware of them, like full stomach. For individual to be aware of the surroundings, four aspects of the sensory process must be present. First, we have stimulus, then reception, impulse conduction, and perception. Stimulus is an agent or act that stimulates a nerve receptor. A receptor is a nerve cell that acts as a receptor by converting the stimulus to a nerve impulse. Most receptors are specific, that is, sensitive to only one type of stimulus, such as visual, auditory, or touch. Impulse conduction, on the other hand, is where the impulse travels along nerve pathways, either to the spinal cord or directly to the brain. For example, auditory impulses travel to the organ of corti in the inner ear. From there, the impulses travel along the 8th cranial nerve to the temporal lobe of the brain. Lastly, we have perception. Perception, or awareness and interpretation of stimuli, takes place in the brain, where specialized brain cells interpret the nature and quality of the sensory stimuli. The client's level of consciousness affects the perception of the stimuli. For the person to receive and interpret stimuli, The brain must be alert, also referred to as arousal. The reticular activating system, or the RAS, in the brainstem is thought to mediate the arousal mechanism. The RAS has two components. We have the reticular excitatory area and the reticular inhibitory area. The reticular excitatory area is responsible for arousal and wakefulness. People have their own zone of optimum arousal, the level at which the person feels comfortable. Sensoristasis is the term used to describe the state in which a person is in optimal arousal. Beyond this comfort zone, people must adapt to the increase or decrease in sensory stimulation. An absence of stimuli from the RAS to the cerebrum results in the brain becoming inactive or useless. The brain has the capacity to adapt to sensory stimuli. For example, a person living in a city may not notice traffic noise that someone from a rural area finds loud and disturbing. Not all sensory stimuli are acted on, some are stored by the memory to be used at a later date. Now let's discuss awareness. It is the ability to perceive internal and external stimuli and to respond appropriately through thought and action. A normal, alert person can assimilate many kinds of stimuli at one time. There are also several states of awareness. We have full consciousness, wherein the patient is alert, oriented to time, place, and person, and understands verbal and written words. Patient can be disoriented, wherein he or she is not oriented to time, place, or person. He or she might be confused, wherein there is reduced awareness, easily bewildered, poor memory, misinterprets stimuli, and there is impaired judgment. Patient can be somnolent, wherein there is extreme drowsiness, but will respond to stimuli. Also, patient can be semi-comatose. He or she can be aroused by extreme or repeated stimuli. And lastly, patient can be in the state of coma, where he or she will not respond to verbal stimuli. A number of factors affect sensory reception and perception, including, first, developmental stage. Perception of sensation is critical to the intellectual, social, physical development of infants and children. Infants learn to recognize the face of their mother or caregiver and establish bonding essential to later emotional development. Young children respond to music by singing and dancing as they begin to interact with their peers in groups. As children grow, they learn to interpret visual and auditory signals when preparing to cross the street. Adults have many learned responses to sensory stimuli. The sudden loss or impairment of any sense, therefore, has a profound effect on a person of any age. Next is culture. An individual's culture often determines the amount of stimulation that a person considers usual or normal. For example, a child reared in a big city, Latino neighborhood, where extended families share responsibilities for all the children, may be accustomed to more stimulation than a child reared in a European American suburb of scattered single-family home. In addition, the normal amount of stimulation associated with ethnic origin, religious affiliation, and income level, for example, also affects the amount of stimulation an individual desires and believes to be meaningful. The sudden change in cultural surroundings experienced by immigrants or visitors to a new country, especially where there are differences in language, dress, and cultural behaviors, may also result in sensory overload or cultural shock. Next is level of stress. During times of increased stress, people may find their senses already overloaded and thus seek to decrease sensory stimulation. For example, a client dealing with physical illness, pain, hospitalization, and diagnostic tests may wish to have only close support people visit. In addition, a child may need the nurse's help to decrease unnecessary stimuli, such as noise, as much as possible. On the other hand, clients may seek sensory stimulation during times of low stress. Next is medications and illness. Certain medications can alter an individual's awareness of environmental stimuli. Narcotics, anti-epileptic agents, and sedatives, for example, can decrease awareness of stimuli. Some antidepressants can also alter perceptions of stimuli. When administering these medications, the nurse is responsible for protecting the client from injury that can result from impaired sensory perception. The nurse should educate clients and their families on the effect of medications produced that may alter sensory perception. Anyone taking several medications concurrently may show alterations in sensory function. Older adults are the greatest risk for such alterations because they may have conditions that alter perception and spatial orientation. Lastly, we have lifestyle and personality. Lifestyle influences the quality and quantity of stimulation to which an individual is accustomed. A client who is employed in a large company may be accustomed to many diverse stimuli, whereas a client who is self-employed and works in the home is exposed to fewer less diverse stimuli. People's personalities also differ in terms of the quantity and quality of stimuli with which they are comfortable. Some people delight in constantly changing stimuli and excitement, whereas others prefer a more structured life with few changes. People become accustomed to certain sensory stimuli, and when these change markedly, an individual may experience discomfort. For example, when clients enter a hospital, they usually experience stimuli that differ in quantity and quality from those to which they are accustomed. These changes may cause clients to become confused and disoriented. Some clients may experience excessive changes in mental alertness, including delusions and hallucinations. Nurses have become increasingly aware of the behaviors that may result from different stimuli. They now pay more attention to color, sound, privacy, and social interaction for clients so that the stimuli more closely resemble those in the home environment. Factors that contribute to alterations in behaviors include sensory deprivation, sensory overload, and sensory deficit. Sensory deprivation is generally thought of as a decrease in or lack of meaningful stimuli. When a person experiences sensory deprivation, the balance in the reticular activating system is disturbed. The RAS is unable to maintain normal stimulation to the cerebral cortex. Because of this reduced stimulation, a person becomes more acutely aware of the remaining stimuli and often perceives these in a distorted manner. The person often experiences alterations in perception, cognition, and emotion. Next is sensory overload. It generally occurs when a person is unable to produce or manage the amount of intensity of sensory stimuli. There are three factors that contribute to sensory overload. First is increased quantity or quality of internal stimuli such as pain, dyspnea, or anxiety. Next is increased quantity or quality of external stimuli, such as a noisy healthcare setting, intrusive diagnostic studies, or contacts with many strangers. And the third is the inability to disregard stimuli selectively, perhaps as a result of nervous system disturbances or medications that stimulate the arousal mechanism. Sensory overload can prevent the brain from ignoring or responding to specific stimuli. Because of the many stimuli, the individual has difficulty perceiving the environment in a way that makes sense. As a result, the individual's thoughts race in many directions, causing restlessness and anxiety. The person usually feels overwhelmed and does not feel in control. It is important for nurses to remember that sights and sounds that are familiar to them often represent overload to clients. People who have sensory overload may appear fatigued. They often cannot internalize new information and they experience cognitive overload. Factors such as pain, lack of sleep, and worry can also contribute to sensory overload. Lastly, we have sensory deficits. It is impaired reception, perception, or both of one or more of the senses. Blindness and deafness are sensory deficits. When the loss of sensory function is gradual, individuals often develop behaviors to compensate for the loss. Sometimes, these behaviors are unconscious. For example, a person with gradual hearing loss in the right ear may unconsciously turn the left ear towards a speaker. However, sudden loss of one of the senses can result in disorientation, and compensatory behavior often takes days or weeks to develop. Clients with sensory deficits are at risk for both sensory deprivation and sensory overload. For example, individuals with visual problems may be unable to read, watch television, or recognize nurses by sight, which could lead to sensory deprivation. On the other hand, blind people often have highly structured home environments, and the diversity and unfamiliarity of the hospital environment can create sensory overload. At the same time, impaired vision often results in an inability to move around readily or socialize with others. Now let's discuss spirituality. To provide holistic care, nurses need to care not only for the physical body and mind, but also need to care in ways that are sensitive to the client's spirit. Spirituality and religion are words that are often used interchangeably by clients and professionals alike. Yet, the nursing literature typically distinguishes them as a separate concept. That is, spirituality is generally thought to refer to the human tendency to seek meaning and purpose in life, inner peace and acceptance, forgiveness and harmony, hope, beauty, and so forth. In contrast, the term religion is usually applied to ritualistic practices and organized beliefs. Spirituality and religion are inherently intertwined. It is important to remember that some people do not accept that there is an ultimate other or a spiritual reality. An agnostic is a person who doubts the existence of God or a supreme being, or believes that the existence of God has not been proven. An atheist is one without belief in a deity. A deity is a God, creator, and supreme being. Most nurses accept a definition of spirituality that allows the assumption of spirituality to be universal. It is essential to ethical nursing care, however, that diverse views regarding spirituality be acknowledged and respected. Spiritual care, also known as spiritual nursing care, should not be prescriptive, such as following of a set guideline for intervening to resolve a client's spiritual problem. Instead, it should be descriptive of ways nurses can offer spiritual support. Spiritual nursing care is an intuitive, interpersonal, altruistic, and integrative expression that is contingent on the nurse's awareness of the transcendent dimension of life, but that reflects the client's reality. At its foundational level, spiritual nursing care is an expression of self. Spiritual nursing care begins from a perspective of being with the client in love and dialogue, but may emerge into therapeutically oriented interventions that take direction from the client's religious or spiritual reality. Although nursing terminology usually uses spiritual care, a few nurses use less prescriptive and probably more appropriate language such as spiritually sensitive nursing care or spiritual nursing care. Regardless of terminology, promising findings from recent studies indicate that such care does affect positive client outcomes such as satisfaction with care. Spiritual distress refers to a disturbance in the belief of value system that provides strength, hope, and meaning. Nanda International categorizes defining characteristics of spiritual distress by whether they reflect an impaired connection with self, others, arts or music, literature, nature, or a power greater than self. Examples of defining characteristics of spiritual distress include expressed lack of hope, meaning of life, inadequate acceptance of self. Expresses feeling abandoned or anger toward power greater than self. Refuse interaction with significant others. Exhibits sudden changes in spiritual practices. Requests or refused to interact with a spiritual leader, and has no interest in nature or in reading spiritual literature. Spiritual health, also known as spiritual wellness or well-being, is often portrayed as the opposite of spiritual distress. Spiritual health is thought to not occur by chance, but by choice. That is, spiritual health results when individuals intentionally seek to strengthen their spiritual muscles, as it were, through various spiritual disciplines, such as prayer, meditation, service, fellowship with similar believers, learning from a spiritual mentor, and worship and study and fasting. Spiritual or religious coping, both positive and negative, has received considerable research attention during the past couple of decades. It refers to the spiritual beliefs or ways of thinking that help people cope with their challenges. Numerous studies have shown that positive religious coping helps clients to adapt to illness, whereas negative religious coping is associated with maladaptation. For example, thinking that illness is a punishment and feeling abandoned by God are related to depressed mood in women with breast cancer. Such negative religious coping also explains in part the link between trauma and post-trauma stress disorder. It is possible for nurses to unethically impose personal spiritual beliefs on clients whose circumstances inherently leave them vulnerable. Observing guidelines for ethical conduct in spiritual caregiving is essential. Here are the following guidelines. First, seek a basic understanding of clients' spiritual needs, resources, and preferences, so you have to assess the patient. Follow the client's expressed wishes regarding spiritual care. Do not prescribe or urge clients to adopt certain spiritual beliefs or practices, and do not pressure them to relinquish such beliefs or practices. Strive to understand personal spirituality and how it influences caregiving. And lastly, provide spiritual care in a way that it is consistent with personal beliefs. Holy days are solemn religious observances and feast days throughout the year, and may include fasting or special foods, reflection, rituals, and prayers. Believers who are seriously ill are often exempted from such requirements. Clients may be used to spend such days with family and attending religious services. Next is sacred texts. People often gain strength and hope from reading religious writings when they are ill or in crisis. Each religion has sacred and authoritative scriptures that provide guidance for its adherents' beliefs and behaviors. Next is sacred symbols. Sacred symbols include jewelry, medals, amulets, icons, totems, or body ornamentations, such as tattoos, that carry religious or spiritual significance. They may be worn to pronounce one's faith, to remind the practitioner of the faith, to provide spiritual protection, or to be the source of comfort or strength. People may wear religious symbols at all times, and they may wish to wear them when they are undergoing diagnostic studies, medical treatment, or surgery. For example, people who are Roman Catholic may carry a rosary for prayer. A Muslim may carry a mala or string of prayer beads. People may have religious icons or statues in their home, car, or place of work as a personal reminder of their faith or as part of a personal place of worship or meditation. Hospitalized clients or long-term care residents may wish to have their spiritual icons or statues with them as a source of comfort. Next is prayer and meditation. Prayer involves human pleading or experiencing the divine, however that is perceived. Some would describe prayer as an inner experience for gaining awareness of self, including self or the eminent manifestation of the divine. These differing perspectives likely reflect the theological variations about how the divine relates to humanity. There are different types of prayer experience. These experiences are categorized as ritual, which is a memorized prayers that can be repeated. We also have petitionary or intercessory prayer when one is requesting something of the divine. We also have colloquial. It is a conversational prayer. Lastly, we have meditational, moments of silence focused on nothing, a meaningful phrase, or a certain aspect of the divine. Although meditational and colloquial prayer experiences have been found to be associated with spiritual well-being and quality of life in healthy adults, rituals and petitionary prayer experiences may be most comforting and appropriate for those who are ill and unable to concentrate. Meditation, on the other hand, is the act of focusing one's thoughts or engaging in self-reflection or contemplation. Some people believe that through deep meditation, one can influence or control physical and psychological functioning and the course of illness. Now let's have the beliefs affecting diet. Many religions have prescriptions regarding diet. It is important that healthcare providers prescribe diet plans with an awareness of the client's dietary and fasting beliefs. There may be rules about which food and beverages are allowed and which are prohibited. For example, Orthodox Jews are not to eat shellfish or pork, and Muslims are not to drink alcoholic beverages or eat pork. Members of the Church of Jesus Christ of Latter-day Saints, or the Mormons, are not to drink caffeinated or alcoholic beverages. Other Catholics may choose not to eat meat on Fridays because this was prescribed in years past. Buddhisms and Hindus are often vegetarian, not wanting to take life to support life. Religious law may also dictate how food is prepared. Next is belief about illness and healing. Clients may have religious beliefs that attribute illness to a spiritual disease or sin. Some clients may ascribe disease to the innate presence of sin and evil in this world, whereas others may believe that disease is a punishment for sin in their past. Indeed, how clients view the divine, interpret good and evil, and so forth, inevitably influences their thinking about illness and decision making about treatment. Healing for such clients may appear to be unrelated to current treatment practices. When relevant, the nurse should assess the client's beliefs related to health and, if possible, include aspects of healing that are part of the client's belief system in the planning of care. Next is belief about dress and modesty. Some religions require that women dress in a conservative manner, which may include wearing sleeves and modestly cut tops and skirts that cover the knees. Many Islamic cultures may require that the body, such as the torso, arms, and legs, be covered, as well as the head. Hindu women accustomed to wearing saris prefer to cover all of the body except arms and feet. Hospital gowns may make women wishing to comply with religious dress codes feel uneasy and uncomfortable. Clients may be especially disconcerted when undergoing diagnostic tests or treatments, such as mammography, that require body parts to be bared or shaved. Nurses need to facilitate respectful solutions at such times. Next is beliefs related to birth. For all religions, the birth of a child is an important event giving cause for celebration. Many religions have specific ritual ceremonies that consecrate the new child to God. For example, while a baby is being born, its Muslim mother may recite a prayer. As soon as it is born, its father or someone else will recite a call to prayer into the infant's ears. Likewise, Hindus will perform a number of religious rituals when a baby is born. Most Christians' parents will have their babies baptized at some point. However, for some, if their infant is dying, they may want a baptism as soon as possible. In such dire circumstances, Christian parents of seriously ill infants may want baptism performed at birth by a religious nurse or primary care provider if a chaplain or clergy person is not present. Next is beliefs related to death. Spiritual and religious beliefs play a significant role in the believer's approach to death, just as they do in the other major life events. Many believe that the person who dies transcends this life for a better place or state of being. Research findings suggest these religious beliefs may influence end-of-life care choices, such as whether to seek hospice care or have an advanced care plan. Some religions have special rituals surrounding dying and death that must be observed by the faithful. Observance of these rituals provides comfort to the dying person and their loved ones. As a nurse, we have to provide presence. Presencing is a term describing the art of being present or just being with a client during an existential moment. Presencing is a gift of self given by the nurse who maintains an attitude of attentiveness towards the client. Thus, nurses who listen attentively to clients yet fail to give of self diminish their effectiveness. Here are the 4 levels or ways of being present for clients. First is presence, when a nurse is physically present but not focused on the client. Second, partial presence, when a nurse is physically present and attending to some task on the client's behalf but not relating to the client on any but the most superficial level. Full presence, which is the third level, it is when a nurse is mentally, emotionally, and physically present, intentionally focusing on the client. And for the fourth level, we have transcendent presence, when a nurse is physically, mentally, emotionally, and spiritually present for a client, involves a transpersonal and transforming experience. Presencing is often the best and sometimes the only intervention to support a client who suffers under circumstances that medical interventions cannot address. When a client is helpless, powerless, and vulnerable, a nurse's presencing can be most beneficial. Rather than worrying about saying or doing the right thing, Nurses should focus on being fully present. In this way, nurses can promote healing, diminish client anxiety, create a sense of safety, and improve both client and their own satisfaction with the interaction. So, how to increase spiritual awareness? Here are the following strategies for nurses who wish to increase their spiritual awareness so that it can impact client positively. First is to write a self-epitaph. Sum up in a couple of lines what is significant about your life or how you would like to be remembered. Next is explore personal end-of-life issues. Imagine having terminal diagnosis. What feelings would you have? What would be your priorities for the time and energy you had left? Next is create a personal loss history. Answer questions such as these. What was your first experience of death? What was the most recent or difficult death in your life? How did you cope? What is your coping styles at times like these? How did you feel your grief? Next is list significant values. Write down what possessions, individuals, activities, roles, personal attributes, and so forth you prized most. And lastly, conduct a spiritual self-assessment. Consider what gives you strength and hope. What makes you joyful or despairing? How do you explain or relate to suffering? And what is your sense of purpose or mission in life? And what nurtures your spirit? You may want to test out client spiritual assessment questions on yourself. Another aspect of a spiritual self-assessment is to reflect on what has influenced your spirituality most. How does the religion of your family affect you? How would you describe your spiritual journey? And importantly, how does your spirituality influence your vocation, your choosing to be a nurse? Now let's proceed to sexuality. All humans are sexual beings, regardless of gender, age, race, socioeconomic status, religious beliefs, physical and mental health, or other demographic factors. We express our sexuality in a variety of ways throughout our lives. Human sexuality is difficult to define. Sexuality is an individually expressed and highly personal phenomenon that evolves from life experiences. Physiological, psychosocial, and cultural factors influence a person's sexuality and lead to the wide range of attitudes and behaviors seen in humans. Satisfying or normal sexual expression can be described as whatever behaviors give pleasure and satisfaction to those adults involved, without threat of coercion or injury to self or others. What constitutes normal sexual expression, however, varies among culture and religions. Now let's proceed to the development of sexuality. The development of sexuality begins with conception and continues throughout the lifespan. We have birth to 12 years, adolescence, young and middle adulthood, and older adult. First, let's discuss birth to 12 years. The ability of human body to experience a sexual response is present before birth. Children would experience masturbation and menstruation. Masturbation happens by the age of 3, and this is an excitation of one's own or another's genital organs by means other than sexual intercourse. And menstruation, on the other hand, is monthly uterine bleeding for girls. For adolescents, during early adolescence, between 12 and 13 years, primary and secondary sex characteristics continue to develop, necessitating more information about body changes. Adolescents would experience dysmenorrhea, which is a painful menstruation prevalent among adolescent females. Cramping, lower abdominal pain, radiating to back and upper thighs, nausea, vomiting, diarrhea, and headaches may occur for a few hours up to 3 days. Dysmenorrhea results from powerful uterine contractions, which causes ischemia and cramping pain. The symptoms of dysmenorrhea are treated with administration of analgesics such as aspirin, application of heat to the abdomen, certain exercises such as abdominal muscle strengthening, biofeedback, and nonsteroidal anti-inflammatory medications such as ibuprofen. In young adulthood, many people form intimate relationships with long-term implications. These relationships may take the form of dating, cohabitation, or marriage. Note, however, that some people do not form intimate relationships until late adulthood and that some never form these types of relationships. For middle adulthood, during middle adulthood, both men and women experience decreased hormonal production, causing the climacteric, usually called menopause, in women. These events often affect the individual's sexual self-concept, body image, and sexual identity. For older adulthood, older adults may define sexuality far more broadly and include in their definition such things as touching, hugging, romantic gestures such as giving or receiving roses, comfort, warmth, dressing up, joy, spirituality, and beauty. Interest in sexual activity is not lost as people age. Now let's discuss sexual health. Sexual health is an individual and constantly changing phenomenon, falling within the wide range of human sexual thoughts, feelings, needs, and desires. For most people, sexual health is not a concern until its absence or impairment is noticed. A person's degree of sexual health is best determined by the individual, sometimes with the assistance of a qualified professional. Sexual health is a state of well-being in relation to sexuality across the lifespan that involves physical, emotional, mental, social, and spiritual dimensions. Sexual health is an inextricable element of human health and is based on a positive, equitable, and respectful approach to sexuality, relationships, and reproduction that is free of coercion, fear, discrimination, stigma, shame, and violence. Sexual health includes the ability to understand the benefits, risks, and responsibilities of sexual behavior, the prevention and care of disease and other adverse outcomes, and the possibility of fulfilling sexual relationships. Now let's have the components of sexual health. 5 critical components of sexual health are sexual self-concept, body image, gender identity, gender role behavior, and androgyny. First is sexual self-concept, which is how one values oneself as a sexual being, determines with whom one will have sex, the gender and kinds of people a person is attracted to, and the values about when, where, with whom, and how one expresses sexuality. A positive sexual self-concept enables the people to form intimate relationships throughout life. A negative sexual self-concept, however, may impede the formation of relationships. Next is body image, which is a central part of the sense of self, and it is constantly changing. Pregnancy, aging, trauma, disease, and therapies can alter an individual's appearance and function, which can affect body image. How a person feels about his or her body is related to one's sexuality. People who feel good about their bodies are likely to be comfortable with and enjoy sexual activity. People who have a poor body image may respond negatively to sexual arousal. Next is gender identity. It is one's self-image as a female or male. More than just the biologic component, It also includes social and cultural norms. Gender identity results from developmental events that may or may not conform to one's apparent biologic sex. Once gender identity is established, it cannot be easily changed. Next is gender role behavior. It is the outward expression of a person's sense of maleness or femaleness, as well as the expression of what is perceived as gender appropriate behavior. Each society defines its roles for males and females. Boys are given reinforcement for behaving in a masculine way, and girls receive reinforcement for exhibiting feminine behaviors. Lastly, we have androgyny, or flexibility in gender roles. It is the belief that most characteristics and behaviors are human qualities that should not be limited to one specific gender or the other. Being androgynous does not mean being sexually neutral or imply anything about one's sexual orientation. Rather, it describes the degree of flexibility a person has regarding gender stereotypic behaviors. Adults who can behave flexibly regarding their sexual roles may adapt better than those who adopt rigid, stereotyped gender roles. Now let's have the varieties of sexuality. There is a tremendous range of variation in how people experience and express their sexuality. There are also many differences in the priority people place on sexuality in their lives. Sexual varieties include sexual orientation, gender identity, and erotic preferences. First, let's have sexual orientation. It is one's attraction to people of the same sex, other sex, or both sexes. Sexual orientation lies along a continuum with a wide range between extremes of exclusive attraction. This is one reason why the number of terms used to describe sexuality is increasing. The term LGBTQQ is frequently used. It stands for lesbian, gay, bisexual, transgender, queer, and questioning. In general, same-sex attraction has been called homosexuality. Women attracted only to women are referred to as lesbians. Men attracted to men are gay, although gay is also a general term for homosexual. Individuals attracted to people of both genders are bisexuals. Someone who identifies with a different gender than their anatomic designation is a transgender person. Someone who rejects gender stereotypes may be considered queer, and those who have not decided on their orientation may be questioning. Many other terms may also be used. The nurse should feel comfortable asking for the client's definition of a term if unsure of its meaning. Western culture is deeply committed to the idea that there are only two sexes. Biologically speaking, however, there are many gradations running from female to male. Sometimes, gender is clear. In other cases, there is a blending of both genders within the same individual, and in some, it is unclear. First, we have intersex. It is a condition in which there are contradictions among chromosomal sex, gonadal sex, internal organs, and external genital appearance. The gender of such an infant is ambiguous. This means that an intersexed person has some parts usually associated with males and some parts usually associated with females. Intersex anatomy may not be apparent at birth. Sometimes it is undetected until puberty, until the person is identified as infertile adult, or until the person dies and is autopsied. For the transgendered person, sexual anatomy contradicts gender identity. Those who are born physically male but are emotionally and psychologically female are called male to female transgenders. Those who are born female but are emotionally and psychologically male are called female to male transgenders. The medical profession considers transgender individuals to have a condition called gender dysphoria or gender identity disorder. There is a strong and persistent feelings of discomfort with one's assigned gender. Lastly, we have cross-dressers. Cross-dressing is dressing in the clothing of the other sex. It makes individuals' outward appearance consistent with their inner identity and gender role and increases their comfort with themselves. Cross-dressers are typically males who cross-dress to express the feminine side of their personality. Usually, cross-dressers are not interested in permanently altering their bodies through surgical means, especially since the majority are comfortable with their original birth identity and behavior in their public and professional lives. Next, we have erotic preferences. Over time, sexual fantasies and single-parent sex are the most common sexual outlets for women and men, single and coupled individuals, and heterosexual and LGBTQ individuals. Masturbation is the ongoing love affair that each of us has with ourselves throughout our lifetime. It is the way we discover our erotic feelings and learn about our sexual response. Mutual masturbation can provide sexual pleasuring and intimacy without hurrying to genital interaction before both partners are ready. Masturbation shared with a partner is a safe alternative to unprotected genital sex. First is male to female or female to female oral genital sex, and it is known technically as cunnilingus. This involves kissing, licking, or sucking of the female genitals, including the mons pubis, vulva, clitoris, labia, and vagina. Fellatio is an oral stimulation of the penis by licking and sucking. The term 69 refers to simultaneous oral genital stimulation by two people. Preconceptions and myths are a major deterrent for those who have not tried oral sex. However, like most sexual practices, oral genital sex is not completely free of the potential for STI transmission, and safe sex practices must be used. Next is anal stimulation. Anal stimulation can be a source of sexual pleasure because the anus has a rich nerve supply. Stimulation may be applied with fingers, mouth, or sex toys such as vibrators. The anus is surrounded by strong muscles, and the rectum contains no natural lubrication. Thus, inserting a finger or penis in the rectum requires relaxation and water-soluble lubricant. A common form of sexuality for heterosexual couples is genital intercourse. Penile to vaginal intercourse, or coitus, can be both physically and emotionally satisfying. Various positions are used for this kind of intercourse. The choice of intercourse positions and activities depends on physical comfort and beliefs, values, and attitudes about different practices. The other form of genital intercourse is anal intercourse, during which the penis is inserted into the anus and rectum of the partner. Anal intercourse is commonly practiced by gay men, but heterosexual couples engage in it as well. Positions for anal intercourse are similar to those for penile to vaginal intercourse, with minor differences due to the position of the anus. Current practice dictates the use of a condom to prevent transmission of infections. Because anorectal tissue is not self-lubricating, a lubricant must be used on the condom. Also, because normal bacterial flora from the bowel can produce infection in other parts of the body, the used condom should be removed and another applied before inserting the penis into other body orifices. There are many other varieties of sexuality. These include several or many partners, nudism, swinging, group sex, fetishism, sexual sadism, and sexual masochism. Now let's proceed to the factors influencing sexuality. Many factors influence a person's sexuality. We have First, family. For the majority of us, the family is the earliest and most enduring social relationship. Families are the fabric of our day-to-day lives and shape the quality of our lives by influencing our outlooks on life, our motivations, our strategies for achievement, and our styles for coping with adversity. Next is culture. Culture influences the sexual nature of dress, rules about marriage, expectations of role behavior, and social responsibilities and sex practices. Next is religion. Religion influences sexual expression. It provides guidelines for sexual behavior and acceptable circumstances for the behavior, as well as prohibited sexual behavior and the consequences of breaking the sexual rules. And lastly, personal expectations and ethics. Although ethics is integral to religion, ethical thoughts and ethical approaches to sexuality can be viewed separately from religion. Cultures have developed written or unwritten codes of conduct based on the ethical principles. Personal expectations concerning sexual behavior come from these cultural norms. What one person's or culture views as bizarre, perverted, or wrong may be natural and right to another. Now let's discuss sexual response cycle. Commonly occurring phases of the human sexual response follow a similar sequence in both female and males, regardless of sexual orientation. It does not matter if the motive for being sexually active is true love or passionate lust. The response cycle starts with the desire phase. This is a conscious sexual desires that starts in the brain. Sexually arousing stimuli, often called as erotic stimuli, may be real or symbolic. Sight, hearing, smell, touch, and imagination of sexual fantasy can all invoke sexual arousal. Sexual desire fluctuates within each person and varies from person to person. Next is excitement phase. It involves two primary physiological changes. Vasocongestion is an increase in the blood flow to various body parts, resulting in erection of the penis and clitoris, and swelling of the labia, testes, and breasts. Vasocongestion stimulates sensory receptors within these body parts that transmit messages to the conscious brain, where they are usually interpreted as pleasurable sensations. When stimulation is continued, vasocongestion increases until it either is released by orgasm or fades away. Next is the orgasmic phase. It is the involuntary climax of sexual tension, accompanied by physiological and psychological release. This phase is the measurable peak of the sexual experience. Although the entire body is involved, the major focus of the orgasm is felt in the pelvic region. Male orgasms usually last 10 to 30 seconds, while female orgasms last 10 to 50 seconds. Men usually have an ejaculation and expel semen as part of their orgasm. Lastly, we have the resolution phase. It is the period of return to the unaroused state. It may last 10 to 15 minutes after orgasm, or longer if there is no orgasm. This phase in females is varied, as some women experience multiple successive orgasms followed by a longer period of resolution. So we have here the different phases of the sexual response cycle of male and female. Now let's have the altered sexual function. It is often difficult to sort out the multiple factors contributing to an individual's or a couple's sexual problems. A number of past and current factors are involved. First, we have your past and current factors: sexual desire disorders, sexual arousal disorders, orgasmic disorders, sexual pain disorders, and problems with satisfaction. For your past and current factors, we have sociocultural factors, psychological factors, cognitive factors, sexual problems, lack of intimacy and feeling, health factors, and many prescription medications. So these factors can greatly affect the individual's or a couple's sexual problems. Next, we have your sexual desire disorders. For most people, sexual desire varies from day to day and over the years. We have your hyposexual desire disorder. This is a deficiency in or absence of sexual fantasies and persistently low interest or a total lack of interest in sexual activity. If both individuals in a relationship are similarly uninterested in sex, there really is no problem. More typically, there is a disparity of sexual needs, and the person with the greater desire becomes dissatisfied with the sexual relationship. The key issue in the relationship is not frequency, but rather the dovetailing of partners' needs. Next is sexual aversion disorder. It is a severe distaste of sexual activity or the thought of sexual activity, which then leads to a phobic avoidance of sex. It occurs in both women and men. Intense emotional dread of an impending sexual interaction also can trigger the physiological symptoms of anxiety, such as sweating, increased heart rate, and extreme muscle tension. The person then stops the sexual interaction or prevents it from even beginning. Next, we have sexual arousal disorder. Sexual arousal refers to the physiological responses and subjective sense of excitement experienced during sexual activity. Lack of lubrication and failure to attain or maintain an erection are the major disorders of the arousal phase. In female sexual arousal disorder, the lack of vaginal lubrication causes discomfort or pain during sexual intercourse. And the diagnosis of male erectile disorder is usually made when the man has erection problems during 25% or more of his sexual interactions. Some men cannot attain a full erection and others lose their erection prior to orgasm. The term commonly applied to this condition, which is impotency, implies that the man is feeble, inadequate, and incompetent. The accurate term is erectile dysfunction, which is objectively descriptive and non-judgmental. Arousal disorder may be diagnosed even when lubrication and erection are adequate if individuals report a persistent or recurring lack of subjective sexual excitement or pleasure. Next, we have your orgasmic disorders. The term commonly applied in the past to women who did not experience an orgasm, we call that as frigid, implied that the woman was totally incapable of responding sexually. The more accurate and objective term is female orgasmic disorder, which simply means that the sexual response stops before orgasm occurs. Pre-orgasmic women have never experienced an orgasm. Compounding the orgasmic difficulty is the associated anxiety. In the preoccupation with orgasm, the real goal of being sexual, mutual pleasuring, and intimacy is lost, and the interchange becomes one of anxiety, frustration, and anger. Some men suffer from male orgasmic disorder. Men with this disorder can maintain an erection for long periods, usually an hour or more, but have extreme difficulty ejaculating, referred to as retarded ejaculation. In heterosexual intercourse, the difficulty may be limited to ejaculation in the vagina. Some women ejaculate after self-stimulation or manual or oral stimulation by the partner, whereas others have great difficulty ejaculating with any type of stimulation. This disorder is much less common than rapid ejaculation. Next is sexual pain disorders. Both men and women can experience dyspareunia. It is a pain during or immediately after intercourse. It is associated with many physiological causes, especially those that inhibit lubrication, skin irritations, vaginal infections, estrogen deficiencies, and use of medications that drive vagina secretions can cause women to experience discomfort with intercourse. Next is vaginismus. It is the involuntary spasm of the outer one-third of the vaginal muscle, making penetration of the vagina painful and sometimes impossible. The woman often experiences desire, excitement, and orgasm with stimulation of the external sexual structures. Attempts at intercourse, however, elicit the involuntary spasm. She may have similar difficulty undergoing pelvic exams and inserting tampons or a diaphragm. We also have vulvodynia. It is a constant, unremitting burning that is localized to the vulva with an acute onset. The girl or woman has problems in sitting, standing, and sleeping related to the intensity of pain. And lastly, we have your vestibulitis. It causes severe pain only on touch or attempted vaginal entry. Half of the women with vestibulitis report lifelong dyspareunia. People with any of these disorders report a negative impact on their sexual functioning and partner relationship, as well as their self-esteem and mental health. And lastly, we have problems with satisfaction. Some people experience sexual desire, arousal, and orgasm, and yet feel dissatisfied with their sexual relationships. These sexual problems are more common related to the emotional tone of the relationship than the physiological response, since giving and receiving pleasure in a mutually intimate relationship are the primary goals of sex for most people. These satisfaction problems may be more disturbing than other types of sexual dysfunctions. I believe this is the end of the part 1 of our lecture on promoting psychosocial health. Thank you so much for listening.